Hello, I'm Stephanie Lucas, and this is my presentation for NSC 892. Antibiotic overuse is the main contributor for the development of antibiotic resistance. According to the CDC, antibiotic-resistant infections are a substantial health and economic burden to the U.S. healthcare system, as well as to patients and their families. The CDC reports that each year in the United States, at least 2 million people become infected with resistant bacteria, and at least 23,000 patients die each year as a direct result of these infections. Primary care is increasingly becoming the focus of antimicrobial stewardship and the fight against global crisis of antibiotic resistance. Primary care providers are the biggest prescribers of antibiotics, and perhaps 3/4 of all used in medical care. And respiratory tract infections are the group of infections most commonly treated. According to Del Mar, respiratory tract infections are spontaneously remitting illnesses often caused by viruses. Treating these viruses with antibiotics only leads to an increase in resistance to these life-saving drugs. The purpose of this project is to decrease antibiotic overuse for the treatment of respiratory tract infections in the primary care setting. This project is geared toward adult patients over the age of 18 diagnosed with an uncomplicated respiratory tract infection. This project would be significant for advanced nursing practice, as antimicrobial stewardship is important in the role of the family nurse practitioner, as a large majority of these advanced practice nurses practice in the primary care outpatient setting. Studies by Little et al. And De La Posa Abad et al. Revealed that randomized groups of delayed antibiotic prescribing versus immediate antibiotics showed no difference in symptom severity nor duration of respiratory symptoms. Little et al. And also Lohr et al. Demonstrated that in studies of antibiotics versus placebo, there also were no differences in symptom severity nor duration of respiratory symptoms. In my proposed intervention plan, patients that are deemed to need immediate antibiotics per the clinician's judgment are given antibiotics during that visit. Those qualifying for immediate antibiotics would include patients with a high fever with a temperature over 101, suspected pneumonia, or if the patient has other comorbidities such as asthma, cancer, or an autoimmune disorder, they would be given immediate antibiotic prescriptions. Patients diagnosed with respiratory tract infections will be educated on the course of their illness, with concentration on days 2 through 4 being the worst for symptoms. They would need a rest along with symptom management, which would include over-the-counter treatments for fever, discomfort, and cough. And this, of course, would be a written, individualized course of treatment that would be given to patients at each visit. Conditions for which to contact a provider. If the patient had a fever over 101, chest pain, an increase in the amount of sputum production and or color and consistency. They would also be educated on the dangers of taking antibiotics when not necessary, such as the increase in antibiotic resistance or acquiring C. difficile, which is an infectious diarrhea caused by antibiotics. The patient would be instructed to call the office if symptoms persisted longer than 2 weeks, and if symptoms did persist or if the patient developed further symptoms listed above, then a reevaluation for antibiotics will be done at that time. And the patient's readiness for change would be assessed after education, with the desired end result being that the patient has a better understanding about the use of antibiotics. Proposed evaluation measures. Ultimately, the main desired outcome would be a reduction in all unnecessary antibiotics without increasing symptoms or causing new symptoms. But this intervention will only be evaluated by looking at those patients potentially receiving antibiotics normally given for respiratory tract infections. Prior to implementing the intervention, a report will be developed using the electronic medical record that includes all patients with a diagnosis of uncomplicated respiratory tract infection, and including any diagnoses that fall into that category, and what antibiotics, if any, were given. This report would be analyzed for the same 3-month period the year prior to implementation of the intervention, so that the patient population and illness trends will be similar to the intervention period. In the study phase, the same report would be utilized for monitoring the use of antibiotics for uncomplicated respiratory tract infections monthly to ensure that delayed antibiotic strategies are being used. The outcome will be measured using the number of patients seen with uncomplicated respiratory tract infections as the denominator and the number of patients receiving antibiotics with this diagnosis as the numerator to get the percentage of patients diagnosed with uncomplicated respiratory tract infections who receive antibiotics. This information will be analyzed monthly, looking for trends in the data. And of course, after a 3-month period, the data would be analyzed and the decision to continue or discontinue the intervention would be made by the interdisciplinary team. So in closing, managing a patient's symptoms is one way to delay prescribing antibiotics in most respiratory tract infections that do not require antibiotics. In the primary care setting, providers could easily educate on the dangers of using antibiotics when not necessary and prescribe over-the-counter medications and treatments to help alleviate symptoms. Delaying antibiotics or not giving an antibiotic at all could help in the fight against antibiotic overuse. Thank you.